And what is really important is getting your intubation technique right so that you can maximize time for withdrawal, going from the signal to the end.
Can we go back, Dave? And I would like to interrupt you because, I mean, you rush to the intubation. Obviously, we first have to intubate, but then can we still focus a little bit more on the withdrawal technique and assessment? So how do you assess the colon? What are the tips to really well assess the colon on withdrawal? Because this is something that we were usually not so well taught during our colonoscopy training.
Do you mind if I come back to that, because it's later in the presentation?
Okay.
Is that okay for you?
Yeah, sure.
Okay. So talking about intubation, because for me, the key to getting maximum withdrawal time, which is what Mikhail just said, is to get in fast, right? Get in fast, safely, with minimal discomfort to the patient. And how do you do that? Well, you use lots of different tricks. We're going to show some of the positions of the colon and how you can use tricks to remove loops to prevent them forming. Maybe use water insertion. You change the patient position and you actively try to reduce loops as you go in to reduce discomfort. So water-assisted intubation, I think, is something that's really taken off in the last few years. It's certainly something that I'm using in my daily practice. It weighs the colon down. You don't get so many loops forming. It lubricates, and it means that you quickly and efficiently can intubate the left colon. There's a nice reference there for you to look at if you want. The concept of preventing loops in colonoscopy requires you to understand a few quick things. So the colon starts like this, short, starts pleated like those curtains. As you start pushing in, you start to stretch it. And as you stretch it, you start to cause pain. So this acute angulation, this being the sigmoid of the scope, here's your tip. You're pushing here, but the tip is doing nothing. You're just pushing on the mesentery. So you get poor response. The hip goes backwards as you push forwards. It's a bad situation for the patient, and they get pain. How do you present?
Dave, can you slow down a little bit? I mean, we have two British characters, but not the only British audience. So maybe some people need to go a little bit slower. Thank you so much.
So to prevent your loop forming, what can you do? Well, you can apply torque. What does that do? It sends this situation and makes it a little bit more like this. And here is the tip of the scope. The tip of the scope has moved forward, as you can see, from where it was in the first place. But the scope, what you've been doing is pulling back. So your tips move forward, but your shaft is being pulled back. And what happens in that situation is, because the scope is straighter, you're getting action at the tip as you push in. Same thing in the transverse. I won't labor these points. You can watch them later. But essentially what it means is that the scope moves from causing a huge problem here, because as you push in, you're pushing in and causing a problem in the sigmoid. You're pushing in and causing a problem at the splenic flexure, both of which can cause pain. And therefore, if you pull back, then you can reduce that situation and make sure that your tip ends up straighter and you end up going down into the cecum. All of these shapes that I've showed you here.
Can you explain us just a little bit, how do you pull back? Is it, because this is something which usually people are asking, how to pull back? Is it just pull back, or you do some other maneuvers while you are doing that? And how much should we pull back? Because this is a common thing.
It's a common thing. It's a very important question. I think that you should pull back until the scope starts to fall back. And the question about how should you pull back depends on what situation you're in. So if you're in, let's go back to this situation. If you're in a situation where you have this problem, which we might call an end spiral loop, if you pull back and you add the required amount of torque, so that would be clockwise torque here most likely, as you pull back, you will see the tip move forward, and the tip will move forward until the point at which it's completely straight in this position. And then as you keep pulling back from there, you will fall back. So it's a little bit of experience, but it's also a little bit understanding what situation you're in. And I would encourage you, if you've never used a magnetic imager before, to get one, or ask Olympus to borrow one, or ask the company. All of the scope companies have one, so you can start to understand these patterns and what's actually happening inside of the patient as you are doing this. So I think that is that answering your question, Miguel?
Perfect.
Okay. So we're going to move on from this now to abdominal pressure. This is also something that you can use to get in quicker. There are a couple of structures. Really, the transverse colon is amenable to abdominal pressure, but also the splenic flexure is. So those are really the 2 points that you can use to prevent loops forming externally. And I said this before, but you should get yourself acquainted with those scope shapes on a magnetic tracker. It will really transform the way that you do colonoscopy. What about moving the patient?
So when do you use this hand?
When do you use hand pressure? I think you use hand pressure predominantly. For me, it's in the transverse to support the tip as you're going through the transverse here. So I think this is amenable, this position, to hand pressure. And also, if you're struggling to get into the ascending colon, or you're struggling to do maneuvers there, I think that supporting the splenic flexure can also help. What doesn't help, I think, is sigmoid pressure, really, because the sigmoid colon is almost retroperitoneal and is almost impossible to compress with hand pressure. So I think those are the common situations. All right, what about moving the patient? So there are lots of times when you can move the patient to help, therapy and withdrawal, but on insertion, that very much depends on what you're doing. This is a nice example. You see here, cecum full of fluid. You see the endoscopist is now moving the patient onto the right side. So it was on the left that was full of fluid, but now you see as we push into the cecum here, which was full of fluid, it's now completely empty of fluid, and you can get a beautiful view of the cecal pole. So that is a good example of how to use position on insertion. And why does that work? In the left lateral position, gravity pushes all of the fluid onto the left side, the part you're intubating, and that means it's all compressed and full of fluid. If you move the patient to the right lateral, it's much more open. So we suggest that if you're having trouble with fluid or position in the left colon intubation, put the patient on the right. The opposite is true of the ascending colon. As you might expect, the dynamics are the other way around. And so if you're having trouble in the right colon, put the patient in the left lateral. And we've summarized that here. So start on the left lateral. If you're having trouble, move the patient to the supine or right lateral. In the transverse, the supine tends to be best. And then in the right colon, the left lateral is best. Often because the cecum comes medially, as we just showed you in the video, the right lateral is the best. This is if using air. If using fluid, you pretty much can get away with the left lateral for the majority of the left colon, and then during withdrawal, you can turn the patient back. You want more on colonoscopy, it's there for you. But as Michael said, you got to the cecum,